right. Thank you so much for joining us tonight. We are honored to welcome Dr. Alexander Volchonok, co-founder of TetraHealth Dentistry. Dr. Volchonok is a dual Ivy League trained biologic board certified periodontist and oral implantologist with advanced expertise in biologic dental surgery, zirconia implants, LANAP, and regenerative protocols. He is trained at the University of Pennsylvania School of Dental Medicine and completed his periodontal specialty training at Columbia. What really sets Dr. Volchonok apart is his advanced residency training in biologic dentistry, surgery, implantology through Tufts University and in Frankfurt, Germany, making him the only periodontist in the United States formally certified in biologic dental surgery. So tonight's conversation is going to focus on jaw cavitations, why they're often missed, how they may impact systemic health, and how biologic surgical approaches aim to support proper healing, long-term wellness. For everyone that's here tonight, if you haven't joined us before, this is a live interactive session. So we do always ask any questions, feel free to drop them in the Q&A that's at the bottom of the screen. We'll go through the whole presentation, and then any questions that you have, we will address them at the end of the presentation with Dr. Volchonok. So thank you so much. We're so grateful to have you here to share your insight. I really appreciate you joining us, and I will go ahead and hand it off to you.
Thank you so much, Kim, and it's a pleasure to be with the oral biologics community here. I'm excited to do this presentation with everyone. So I'm going to share the screen here. Just give me a quick thumbs up if everything is looking good. We'll kind of maximize it here. Yeah, just give me a
Yep,
thumbs up.
looks good on our end.
All right, excellent, excellent. All right, everyone. Well, thank you so much. I hope everyone's year is off to a great start. I'm really excited to be back with the oral biologics community here to talk about one of the probably most important topics in biologic dentistry. I think this is one of the areas that's going to be growing exponentially in terms of knowledge base, research, and treatment needs. So I'm going to really talk about this. We're going to talk about the prevention approaches, treatment, clinical considerations for healing. And we're going to kind of take a really deep dive into this, a scientific approach into this. And I will share the TetraHealth protocols for how we are managing jaw cavitations and having success with treating this condition. Kim has done a wonderful introduction to me, so I don't need to spend much time highlighting here. But I do want to point out that it is really important for there to be biologic dental surgical training to do cavitation surgeries. And there's actually even organizations that create certification, such as the Academy of Medicine and Oral Regeneration, that focus on this and promote this education. So this is an important criteria that you want to make sure that your doctors or your surgeons are doing. This is different than conventional dental surgery. Unfortunately, as of right now, this is not taught in normal programs. So this is something that you need to get additional education and knowledge in, even beyond biologic dental training. So this is a cornerstone of what we do in our practice. As many of you may know, or if you're new to TetraHealth, you will see, we are a biologic dental specialized team. There's 5 doctors that comprise our team, and we do everything from restorative to surgical and even orthodontic and airway-driven therapies. Cavitation surgeries is one of the things that I do and something that I'm focused on in the practice. But we have a mission with what we do in the way that we take care of patients. We believe in taking an integrative approach, and we believe in taking a research and scientific-based approach, combining the latest advances in dental medicine and holistic treatments, utilizing the most biocompatible and biologic materials to elevate your health and well-being. What we're going to talk about today, we're going to talk about how jaw cavitation, what is a jaw cavitation and how do they form? How do you properly diagnose a jaw cavitation? What is the proper treatment protocols for this? And we'll go over 2 clinical cases at the end so patients and people can be aware of what's involved with the treatment of this condition. So let's start with the first thing. What is a jaw cavitation and how does it form? So a jaw cavitation is defined as a hollow or necrotic space in the bone marrow of the jaw. Necrotic means that bone area is dead or infected. So those spaces, if you look at the illustration, the images above, you can see what that can look like clinically. The jawbone on the left image is what normal healthy bone would look like. You'd see a nice white marrow space with dense trabeculation or sponge-like characteristic to the bone, whereas a cavitation will be a darker space that loses that bone density and it'll have those voids. In some cases, there are even other terms for this, whether it is fatty degenerative osteonecrosis of the jaw or Nico lesions, neuralgia-inducing cavitational osteonecrosis, if there are neurologic symptoms such as pain. And that is a clinical representation of what it can look like. The image on the right, you can see a fatty area within the bone. Fat within the bone is an indication that the bone has been injured. This is not a normal presentation of what we should see in the bone. And so when we focus on what is a cavitation, this is a deviation from what normal healthy bone is. And as a result, there's a different inflammatory response that we see there. In cavitation lesions, there's a significant upregulation of inflammatory mediators. These are signaling molecules that tell the body there's a problem, that there's inflammation in the area. Because of adjacent blood vessels like arteries and veins, these signal pathways can travel throughout the body and activate signal receptors on other organ systems, everything from the brain to the heart to the gut and the immune system as a whole. Some recent research, even as of the last 5 years, have been looking at sampling these cavitation areas and looking for these uptick in these inflammatory markers. And the bar graph on the left shows an example of a patient who has a significant upregulation of RANTES, which is one of the markers that we look for systemic inflammation, that is significantly higher than normal jawbone. So that's an example of some of the signals that come from this area. Histologically, in the image in the middle, we would see what cells are in the area. Normally, we should not see a heavy density of inflammatory cells. These are those dark purple spots in the area. But in the cavitation area, there's an immune response. The body is trying to fight or suppress the issue that's going on there. And so there's a significant buildup of inflammatory cells. In many instances, when I go in and I treat these areas, I even find an abundance of pathogenic bacteria, viruses, even fungal infections that can be in those sites. All of this, whether it's the injury to the bone, the bacterial buildup, or an inflammatory response, all activate the immune system and can trigger anything from systemic inflammation to even autoimmune responses. So this is a significant finding and a very, very important thing to deal with. Furthermore, these sites can act as chronic inflammatory signal generators and even pathogen reservoirs, meaning that the body does not have the ability to target and eliminate these pathogenic bacteria from these sites, and there are symptoms that patients will experience. And we'll talk about that and we'll look out for some of those red flags shortly. But some key characteristics that we will find in a cavitation is that there's poor blood supply. All right, that bone does not have an ability for blood vessels to come into that area because of that dead or necrotic bone, which means that there's limited immune surveillance. There's a limited ability for immune cells and even medications such as antibiotics or natural therapeutics to be able to get to that site without surgically treating it. Furthermore, the environment is low in oxygen, something we call an anaerobic environment, which is very conducive to an uptick in pathogens. There's high concentrations of inflammatory mediators and toxins, whether those are produced by the body or even produced by the bacteria and fungus in those sites. And most importantly, in many of these instances, the body's immune response to detect disease locally at that area can be turned off by these pathogens, meaning that this symptom or this issue is often asymptomatic or silent. So I think of these areas as almost a silent alarm going off in the body. We don't feel anything going on, but this beacon of inflammatory signals is entering our bloodstream and activating inflammation throughout the body. And this is why there are so many patients that will have some systemic symptoms that are manifesting even prior to the diagnosis of the cavitations, at least for now. My hope is with this presentation and with an increased awareness of what's going on, patients can start screening for cavitations first and foremost, and they won't walk around with these issues for decades at a time. So how do these cavitations form? Cavitations form as a result of incomplete or compromised healing following an infection or injury to the jawbone. Cavitations don't form in areas of healthy bone. They don't form in areas behind wisdom teeth if there's never been any trauma or issue to that. I know there's a lot of misconception about cavitations, and one of my goals today is to try to clear that up. But this illustration, this image here, talks about many of the ways cavitations can form, whether there's trauma and fractures to the teeth, root canal therapies that become infected and form cysts, dead necrotic teeth that spew toxins and pathogens into the jawbone and aren't properly cleaned out, periodontal disease, gum disease that is affecting the quality and the health of the jawbone in the area. Even if the tooth is removed, those residual pathogens can be left behind. Sometimes, due to surgery, root fragments can also be left behind, and those can create certain issues. And even impacted wisdom teeth that have partial exposure, exposed bacteria into the sites can be an issue. And that is a common scenario that we're seeing because those areas may not always be cleaned properly. But important takeaway is that for a cavitation to form, it happens where there's incomplete or compromised healing after an injury to the jawbone. So what are some of the common dental procedures that result in cavitations? Probably the number one most common one is wisdom tooth extraction with incomplete removal of the periodontal ligament or the dental follicle. This is doctor error. And so what I mean by this is that when teeth are removed, it's important to clean out the site thoroughly. But sometimes with wisdom teeth, it's about speed, it's about efficiency. And surgeons who are not trained in biologic protocols don't respect the biology and don't clean out that area sufficiently. And there can be residual tooth fragments, there can even be tissues, dental follicle, or even ligament that's left behind that prevents the bone from forming in that site, allowing bacteria to harbor in the area. The image on the right shows an example of what a impacted wisdom tooth can look like. And we can see the decay, the brown areas on the tooth. You can see some pus even on the backside of the gum and buildup of inflammation around that area that even just taking out the tooth alone will not treat that issue. Sometimes there can be extractions, complications from extractions, such as dry socket, whether that happens from a wisdom tooth or a natural tooth. A dry socket is a condition when there's a loss of the blood clot, and so the bone will not heal appropriately or heal properly if it's not managed in the proper biologic way. Root canal therapy, such as this x-ray that I'm showing here in this image, there's a sign of inflammation and infection beyond the apex of the roots, that dark shadow, that dark area. And this is something that even after the tooth is removed, must be cleaned out because if that pathogen, if that cyst is left behind, that area will form a cavitation. Sometimes dental materials may be even left behind. The tooth on the left in the x-ray shows gutta-percha filling and sealer filling after a root canal therapy that's gotten embedded beyond the apex of the tooth, and now it's its own chronic irritant within the jawbone. And that's some of the things that we try to clean out when we do the surgeries, and one of the things that we definitely want to prevent in the initial therapeutic process. And also infections, necrotic teeth with periapical pathology, whether that's due to dental decay, due to gum disease, any type of infection or necrotic teeth need to be removed and carefully cleaned out so all that bacteria and toxin load is eliminated from that area. This is all imperative to try to minimize the formation of cavitations. But this is some novel research I want to share. And one of the things that I'm very proud to be a part of in terms of my biologic training and continued knowledge base with this, new research, even as recent as summer of 2025, so this is not even 6 months old or just about 6 months old at this point, has shown that cavitations can also form as part of the normal remodeling process of socket healing. So even in a normal extraction in a healthy patient, that area will start to contract when the tooth is removed. Initially, a blood clot will form in the area, and the bone will start to come together, almost like we're pinching it together from all sides. But there can be some residual spaces, like in the illustration on the right, where there's a little void in the middle of the bone, and that is a cavitation. One of the ways to prevent this is the importance of using bone grafts and proper biologic extraction protocols at the time of tooth extraction. So, not always are cavitations just from a error in treatment or approach, but we're actually learning that this is something that can develop as part of the normal healing process. So, biologic protocols are critical to minimize that risk, and there's going to be an importance for the way that we handle those sites after the tooth is removed. And we're going to talk about that a little bit. And we've actually had a previous webinar with oral biologics talking about the extraction protocols. So I would recommend anyone watching that if they're interested in learning more about that. But this is some of the things we can see from that study here, right? Premature closure of the occlusal part of the socket, along with socket collapse, results in the formation of these cavitations. And utilizing novel regenerative approaches, grafting and membranes, what we'll call the guided open wound healing concept, may be a very unique approach to this, and we'll discuss that.
Dr.
So,
Ving, I'm so sorry to
yeah,
interrupt you. I just had a few comments come in. Actually, everyone would prefer just seeing your slides
yeah.
because there's a couple photos I think that you were showing and your body was blocking it a little. So
Oh, yes, okay.
that's my fault. I always instruct everyone to kind of share their screen. Other requests came through in previous that they'd like to see the speaker speaking. So this one, if you since you have so many great images, if you could
Yeah.
share the screen regularly when you do the screen share
Okay.
on your
Yeah. Is this
perfect.
better?
That's awesome. Thank you. Sorry to interrupt you.
Okay. I guess no one wants to see the handsome face. I got it. I got
I-
it. But yeah, of course, if there's anything that was missed or that's important, I'll try to get through that. We'll have a great Q&A session at the end. This is also going to be recorded, and I'll be happy to also post a summary of the slides too. If there's any images that were missed, that'd be important to have. So let's talk about diagnosis now. All right. So we now understand how these things can form. We understand that they can form spontaneously, they can form from injury, and there's a lot of oral and systemic pathology that can happen. So, how do you know if you have a cavitation? How do you diagnose it? So, unfortunately, cavitations are often a hidden issue. All right. And what I mean by that is that they're hidden not just to patients, but they actually are even hidden to most dentists. And this is one of the reasons why there's so little knowledge about this, even within the educated dental communities, within the dental schools. I went to the University of Pennsylvania, I went to Columbia. In neither program did I hear the word or learn about this process at any point in time. This I only learned after continuing education and diving deeper. And I'll tell you one of the reasons why I think that happens is that most dental diagnostics are built on two-dimensional x-rays. So the image on the left, an image A, is an image of two teeth with a regular traditional dental x-ray. And if I were to show this image to most dentists, they would say that they don't see anything wrong with these teeth, that they're completely normal. Images B, C, and D are actually the same exact teeth, but with a 3D view. And what you can see outlined in red is an infection and cyst emerging from both of the roots of the first and second molar tooth, as well as a significant inflammation in the sinus area above it. This is something that we wouldn't completely miss on a conventional 2D image like on the left, but is actually quite obvious and important to find if we were to use 3D images like what we see here on the right. And what are some of the limitations? Why can 2D imaging miss this? Well, first of all, dense bone can mask any bone loss and infection on a 2D image because everything gets crushed together in that image. And so if the problem is within the middle of the bone, in that marrow space, like what a cavitation normally is, it tends to get hidden by the dense outer and inner walls of bone. We also know from radiology studies that dental infections, an infected tooth, needs to have about 50% bone loss before you can see that come up on a traditional two-dimensional X-ray, which means that there's usually about a 6-month delay, if not more, between the starting process of an infection and loss of bone and when it's first picked up on a 2D radiographic image. And so this delay can not only create more symptoms and more pathology, but obviously it creates more significant infection size and more significant bone loss. This here is a 3D image. All right. And in a 3D image, we can see these voids, which I've marked with the yellow arrows, that clearly demarcate where the cavitation sites are. And these have happened after the extraction of a wisdom tooth. And I saw a patient that came to me, she had the teeth out, and the scan obviously showed these areas. But if we were to look at how dense the bone is around these sites, we would never catch this in a traditional two-dimensional image. So periapical images and panoramic X-rays are not sufficient to identify cavitations. The gold standard is a 3D CBCT scan. So if anyone is suspecting or concerned about cavitations, it's important to understand that you cannot diagnose it off a two-dimensional image. You need to get a 3D CBCT scan. Often, oral symptoms are preceded by systemic symptoms, especially in the cases of cavitations. So not only is it hidden, this condition hidden to dentists on x-rays, but oftentimes the symptoms are hidden to patients as well. So what are some of the things that we find systemically that we would consider to be a red flag to screen for in the case of cavitations? Facial pain, pressure, or temporomandibular joint issues, TMJ issues, are really big signs. Headaches, fatigue, brain fog, neurological diseases is an indication that something can be going on through the close vascularization between the jaws and the brain. Cardiovascular diseases, cancers, autoimmune diseases are also key factors to take a look beyond the head and neck area. So issues such as breast cancers can often arise, or immune conditions of the gut, the joints, the skin. These are key things that we want to look at because these pathogenic bacteria do not just stay within the bone and they do not stay within the cavitation. They can travel. And another red flag, I'd say, is unresolved chronic disease. So for anyone on here who is a medical physician, a functional medicine doctor, a wellness coach, you may find that you have clients or patients who you're putting through treatment and they're improving and all of a sudden they plateau or they get stuck. And this is one of the key things that should be screened for. Take a look for cavitations because this may be one of the things that is holding patients back from full systemic recovery. Today, there's also some amazing technology available that can take those 3D images even a step further. There's a technology out of Germany called Visiogenics, which is an enhanced 3D visualization, which we utilize not only to help identify the cavitation, but truly map out that area so we know exactly where the cavitation site is, how close it is to important anatomical structures. For example, for this patient, this image, that yellow dot represents the nerve. And we see that this cavitation is sitting very, very close to that nerve. And so I want to have this map and this plan so I know exactly where I'd want to go and how much distance I have to operate so that we don't have any other issues arise from the treatment of a cavitation. So CT scans are good for identifying them. Visualization technologies are good for planning and being able to treat the issues. So what is the proper treatment? So if we understand that the cavitations are present, what do we do? What is the proper treatment for jaw cavitations? There are three keys to success. First and foremost, we need to prepare the terrain. We need to address oral and systemic inflammation to optimize the body for surgery. The body is not going to be able to recover properly if it's depleted of necessary nutrients or fighting many, many different battles at the same time. Another key is prevention. Preventing cavitation formation in the first place is the best way to avoid having to deal with this. And there's a biologic extraction protocol that's established and in place to minimize the risks of cavitation formation during a normal tooth extraction process. And it's very, very important that teeth are removed following this protocol because this would drive down significantly the number of cavitations that patients will have. If cavitations are present, then they need to be treated with a minimally invasive and regenerative protocol. And we'll go into detail about all these things. So, what we call preparing the terrain, setting up the body and the mouth for success. With salivary testing, which is new technology in the field of periodontics and in biologic dental therapies, we can screen a patient's mouth for their existing bacterial levels for pathogenic bacteria. If a patient presents with high levels of pathogenic bacteria, we know that we need to clean that area up first, whether that's due to gum disease or dental decay. This should be addressed prior to doing the cavitation treatment because we do not want that site recontaminated with these pathogens when we go to treat that. We also need to help support the body properly, and we want to utilize proper nutrition and supplementation in order to make sure the body has the proper immune reserves, open detox pathways, and the necessary building blocks for new bone formation and tissue formation. And I can't speak highly enough to some of the services that Biologics does with this, especially with our patients, because this is an important driver to have success with treatment. It's not just about the surgery. We need to prepare the mouth and the body for this treatment. I'll also touch on the fact that it's important to maintain oral health even after the treatment because the development of new bone in the area of the cavitation does not happen instantaneously. It can take from anywhere from 6 to 18 months, depending on the size of the cavitation, for new bone to fully form in that area. And so we would recommend patients have a full mouth periodontal cleaning every 3 months after the treatment of the cavitation to ensure that bacterial levels and inflammatory markers continue to stay low. If a tooth needs to come out, and we highlighted this biologic extraction protocol, and I'll reference one more time to go back to listen to the previous seminar where we go really in depth with this, but I'll give the high level review here. There's a few concepts that we need to focus. The first one is utilizing an atraumatic extraction technique, meaning do the most minimal amount of damage to the bone so that our surgical technique is not a source of new injury to the bone, which will create cavitations. All right, so we need to preserve existing healthy bone and gum. Some of the techniques we talk about, especially when we're removing molar teeth, is sectioning or splitting the tooth into smaller roots or the smaller pieces so that there's not a lot of force on the bone, and preserving an intact gum margin around the site and bone margins around the site in order to make sure that we have the most opportune site for healing that area. Like the image on the right, you can see after the tooth is removed, there's bone still present in the space between the roots, and the gum line is completely intact around that area. When we follow the biologic extraction protocol, we want to also detoxify the site and then focus on a regenerative protocol. So let's take a look at that because once the tooth is removed, that is where the work begins. This is the biologic concept. This is where the difference between conventional oral surgery and biologic oral surgery start to display. There's a lot of things that are done to properly treat the tooth. And this is Dr. Gennady is one of my mentors. He's one of my professors. And so this is one of the things that he would always say. Once the tooth is out, the work begins. And that's a reminder to do the protocols in a biologic way. So what ends up happening? After a tooth is removed, we first will mechanically clean out the area. We'll remove any toxin or bacteria in the site. We will then use ozone to disinfect the area because ozone can penetrate beyond the bone margins and then we'll utilize a laser to remove any diseased bone or residual diseased tissue. That is all critical to make sure that there's no periodontal ligaments left behind, no diseased or sclerotic bone, and minimize any residual bacteria in that area so the body and the immune system can clean that up. We then also want to focus on a regenerative protocol. And this is very, very important because not all biologic dental surgeons are aware of the importance of bone grafting. Many still just fill the area with PRF, platelet-rich fibrin, and that is not enough. The research today is clear. If you do not use bone grafts, you will get cavitations. The area will shrink, there will be residual cavitation, and that is not a conducive protocol to prevent this problem. So when we graft a site, there is a concept called guided open wound healing, where you use a bone mineral graft, platelet-rich fibrin, and a membrane, something to exclude the tissue from going into that area to allow more bone formation. The benefits of this approach is that it's going to preserve more bone volume, it's going to accelerate the healing process, and importantly, prevent cavitation formation. In certain cases, if a tooth is removed and all these protocols are followed, there's the opportunity to place an immediate implant, meaning an implant can be put into that site as long as the remaining bone is healthy and the implant is being put in an area away from any past infection or past disease. And we could talk about that in the future. So, cavitation surgery. What is the TetraHealth protocol for this? What do we do in our practice when we treat it? So first and foremost, proper diagnosis. A CBCT scan is critical. We send those scans off for visualization, or I will do the visualization process myself to plan the surgery and to plan the access and be aware of any important anatomical structures. We then want the patient to go through a pre-surgical preparation process. Both the mouth and the body need to be in an opportune state to be able to form bone and to heal these areas. When we do get into treatment, we utilize laser therapies to have minimal damage to access the cavitation. There is no possible way to treat a cavitation without direct access to the site. Ozone injections do not work. They don't pass through that dense bone. Antibiotics do not work because there is no blood supply or healthy blood supply to these areas of dead bone. We have to go in and we have to clean them. So if we have to do that, the least invasive way to do that to the bone is with the help of a laser, specifically an erbium YAG laser, which is what we use. Once we have access, we'll also utilize the laser and ozone therapies to disinfect the site, cleaning out any cystic tissue, any infection, anything that is a pathological sign until we see healthy margins of bone. And healthy bone is bleeding bone. So we are looking for bone that is vascular, that is alive. The visualization helps us know that. It gives us measurements. All right. But clinically, at the time of surgery, I'm looking for bleeding bone. And that's the key. We then will follow a regenerative therapy. Again, PRF does not work alone in an extraction site. It will not work alone in a cavitation site. You will end up with a residual cavitation defect, which I see all the time and treat all the time. It is very important to combine that PRF with a bone mineral graft and also utilize a membrane to exclude that tissue to facilitate the healing and recovery process. This is a concept that in reality we've known for close to 40, 50 years through periodontal and oral surgery research that we are now fundamentally applying to cavitation sites, and we're seeing a tremendous difference in the outcome when we follow this protocol. But the body and that site is not done at the time of surgery. And it's very important to understand that once the surgery is completed, that's day one of the bone reformation process. and it's critical to support the body and support the jaw in the healing process. So this can incorporate things like IV drips, proper nutritional supplements, proper diet, stress relief, proper sleep, and even in-office modalities that we can offer patients like lymphatic drainage therapies like flow presso and red light therapies that enhance blood flow to the area and facilitate healing. It is a process. It is a protocol. And it's one of the reasons why I don't call it cavitation treatment because it's not done in one day. It's a specific protocol we have to follow, even predating the actual day of the surgery to have success. We need to prepare the body, handle the surgery in the most minimally invasive and maximally effective way, and then support the body's healing throughout the process going forward. And that's one of the things that if patients are looking to do cavitation therapy, it's very, very important to have a good supportive team in place. And I couldn't commend highly, any more highly, how great the oral biologics team is to do this. We'll now share some clinical cases. For anyone who's watching, I want to just quickly point out that we will show cavitation sites. I will show them up close because I think it's important to understand what we're seeing there. Some of those images are graphic, so if you don't want to see that, this is a good time to kind of turn away, or just listen in as I'm talking through it. Okay. So our first patient is a 37-year-old male. He's a hospital anesthesiologist, so medical doctor himself. No significant medical history. His primary concern was that he was having severe pain on the lower right molar, lower right part of his jaw, with deep pocketing around the gum line of an infected root canal tooth. This pain was at the point when I saw him, it has been ongoing at this point for close to 6 months. And he was told by a previous surgeon that the treatment should just involve removing a part of the wisdom tooth. That treatment was done by that surgeon. The healing did not result in a resolution of the symptoms. He was still in pain, and he had to come back and have residual treatment to remove that root tip. That surgery also did not heal well, and he was on antibiotics for over a month as part of that process. Since then, at that point, he was in chronic pain, requiring daily pain medication as well. This was tough for him to work because he himself has to take care of patients in the hospital. He actually is also, at that time, a relatively new father with a 6-month-old at home, and it was debilitating for his lack of ability to sleep and recover. This is the site. So when we took a scan of him, this is what I'm seeing in the area. On that site, I'm going to highlight it here. The circle represents, the big circle on the left represents the cavitation area. And the cavitation area was so extensive that it actually put a hole through the entire jawbone. And this site does not have normal bone marrow, does not have normal blood supply. It's an extensive, extensive infection. And it's very close and very proximate to the nerve within his jaw. Just adjacent to it on the right side of the screen, there's a circle as well. And I highlight the infection at the apex of the root canal treated tooth, which in my opinion is one of the key things that was contributing to the lack of healing in this area. And this treatment of the wisdom tooth alone was not enough to regenerate any healthy bone in the area because of this adjacent infection in the site. Furthermore, with the arrow, I highlight that there were still pieces of the wisdom tooth left behind. That dense white area in the jawbone is actually a fragment or piece of enamel that's still there. The presence of enamel or that fragment would prevent the normal closure of the bone in that area. That site essentially had no chance to properly heal. And in his case, we would classify this actually as a Nico area because of the significant neuralgia, the significant pain that this patient was dealing with as a result of this surgery. This is a rendering, a 3D rendering of the site. And again, in the large circle, we can see the extensive cavitation. From a size perspective, this is really large. This is a large cavitation. The arrow pointing to that root fragment on the left and the infection at the apex of the root canal treated tooth on the right. The treatment for this patient was that we have to go back in, clean out the cavitation site, and remove the infected root canal treated tooth in order for this bone to heal. Also realize this is the third time, probably within a 2-month period, that surgery is being performed in this area. So the quality of the blood supply, the quality of the gum, the quality of the bone is very poor for proper healing. So we need to focus on our protocols extensively to make sure that we have proper recovery and healing. The arrows on the right side image actually demonstrate perforations through the jawbone itself. So there is a hole on the outer part of the jawbone, what we call the buccal bone, and a hole on the lingual or tongue side of the bone. So it's almost like a gunshot wound or a bullet hole through the entire jawbone here, which is a very significant and challenging defect to treat. To complicate matters even worse, at the very apex, at the very bottom of this cavitation, sits the nerve for this patient's entire jaw, providing sensation to the lower jaw and also to the lip on the right side. So we had to be very careful in our treatment approach to clean out the cavitation properly. And this is why it's so important to utilize laser and ozone therapy, because these are much gentler techniques to clean that site. And then we need to try to rebuild this bone. If we were just to put PRF in this area and close it, this would have no chance to properly heal. So after the disinfection process, I'm looking for healthy bleeding bone margins. And once I see that, that is when I'll put the bone mineral graft in the area, and it's covered with a biologic membrane. So in this case, I chose to use a non-resorbable PTFE membrane, meaning a membrane that I had to come back to and remove, mainly because of how extensive this defect is, how big the infection is. I needed something that can last to allow for proper healing in that site, to give time for this bone to mature. The image on the right shows what it looks like when the membrane is sealed over the bone, and then the tissues are closed over top of that. So this is how the patient finished after the surgery. The gum tissues are closed over that site. And the x-ray on the right is taken at the time of surgery to show the bone fill of the extraction site as well as the cavitation area. But the reality is, as I've said, the 2D x-ray is not enough to let you know if things are healing properly. We have a protocol in place that we will reevaluate the patients 6 months after the cavitation treatment to see how the bone reformation process looks. All right, and those will be some of the things that I'll show you here in a moment. This is the patient's healing timeline. We can see at 1 week, the tissues stay closed. There's a nice pink color to the gum, which is a very positive sign that things are moving in the right direction. On the image on the right-hand side, we can see at 3 weeks that there's a partial exposure of that membrane. That white spot on the backside of the tooth is the PTFE membrane. And that is one of the things that we would expect to happen with a large defect like this. And it's one of the reasons why I'm choosing to use the membrane I did, because we can go in and remove part or all of that membrane as needed to give the body time for bone formation to have a head start. By the time we removed this membrane at about 6 weeks, the bone had a significant head start on the healing process. This patient was also supported with antibiotic therapy because of the extent of infection. And we also give patients probiotics and vitamin supplements when we utilize antibiotics and do this surgery. And we also utilize the homeopathic post-surgical recovery kit to keep that area clean and allow the body to heal, because we do not want new bacteria getting into those sites. The image on the left is what you've seen before. This is the cavitation site prior to treatment with the infected root canal tooth adjacent to it. I'm happy to report the image on the right 6 months later when we come back to it. And you can see in the circle how much bone density has reformed in the area, right? Which is a testament to the healing process. And even in the lower parts where you see the arrow, you see that the outer wall of bone was also able to reform. So that through and through defect, we've been able to correct and to fix. And utilizing proper biologic surgical protocols is what allows this process to not only work, but also form new bone in that area. When we look through this scan now, we don't see any residual cavitation. And that's very, very important because I do have many patients in my practice who have already been treated for cavitations in the past, and these issues have still relapsed. And one of the key things is the new knowledge in terms of surgical techniques on the importance of grafting and utilization of membranes and proper visualization to ensure that the entire defect is cleaned out properly the first time. Most importantly, on the human basis, the patient says, finally, no more pain, and I have my life back. And for someone who is a fellow clinician, takes care of patients, someone who is a fellow father, it really means a lot to me when I know that this person can return back to the things that matter most, their work, their gifts, and their family. I'll also share a more recent case. This will be the last case, but this is an important one. This is a 41-year-old male patient. He is a firefighter, former smoker, and has multiple systemic symptoms that began approximately 2 years ago. And he was referred to me by a biologic dentist. If Dr. Fazio is on the call here, I want to give a shout out to him for recognizing this issue and helping this patient get the proper treatment. The primary concern that this patient was having was not oral, it was systemic. Severe bloating and GI upsets, despite proper diet and numerous efforts of going to the gym and trying to be healthy. Recently, he also developed a ringing in his right ear, and he would lose his balance for periods of about 20 minutes at a time, which you can understand as a firefighter is extremely risky. So he actually had to go on medical leave as a result of these issues. When I asked him about his dental history treatment, he told me that he had his wisdom teeth removed in his early 20s with no notable complications, which is what I hear pretty much all the time. But interestingly, he also did have a failing root canal treated tooth removed 2 years ago. This is the missing tooth in the space on the photograph. The wisdom tooth site that we're going to talk about is behind that last tooth. So the missing space is where the root canal tooth was. And he said when he had that root canal tooth removed, which was infected, his symptoms initially resolved. He was starting to feel better. His gut was feeling better. But then shortly, the symptoms returned. The patient had some recent ozone injection treatments, which did not seem to help with the resolution of any symptoms. And he was referred over to me to address the cavitation sites. When we took a scan of the patient, we can see two key areas in that lower right side. Now, there is several other things going on with this patient, but for brevity and keeping it tight with this presentation, we're going to focus specifically on the cavitations. So in the area where he had a previous wisdom tooth, there was a smaller site. And in the area where he had the tooth removed 2 years ago, there was a very large site. And so when we take a look at this on the 3D scan, we could see in the area where the tooth is removed, I'm going to mark the area in blue to represent the cavitation. And interestingly, the cavitation looks exactly like the roots of the former tooth that were there. We would expect after 2 years of healing that there should be at least partial regeneration of the area, if not complete healing. That's not the case here. This bone never properly healed, and we can see that clearly with a 3D scan. Secondly, there was the area of the past wisdom tooth. And that area also presented with a cavitation, which I'm marking here in yellow on the scan. So this mapping is very helpful for me in order to understand the approach I want to take and the treatment that I want to do. Because both of these areas were on the same side of the mouth, we decided to treat them simultaneously in one surgery. The patient was prepped and primed for the procedure, and then when we were ready for the surgery, this is what the area looked like. I'm going to start on the right side of the screen to show site number 30. This is where the previous root canal treated tooth was. After accessing the area of the gum, a giant void throughout the bone was seen. So this is the past extraction site that never healed. So we needed to remove all the infected and diseased bone in that area to prepare that site for healing. And the area in the back on the left side of the screen, number 32, is the wisdom tooth cavitation area. There was a thin shell of bone over top, which we removed with the laser, and then we dropped into this area of the cavitation. I say oftentimes treating a cavitation is a little bit like cracking an egg. There's a hard outer shell, but a very goopy middle. And once we get through that shell, the purpose is to clean out all that goop. All right. And that is what we find in these cavitation sites. That's what these areas look like when we go to treat them. We make the most minimal access possible with the help of the laser so that I can get to the healthy bone margins. Traditionally, usage of drills or more extensive or more invasive treatments would create more bone injury, the exact thing we're trying to avoid when we do cavitation treatment. So this is why it's so important to access this with the laser, because it does not heat the bone and it does not create extensive vibration and fractures within the bone space, which is why this is so far superior to utilizing other treatment techniques such as using drills or even chisels for that matter. So this is what the x-rays look like after the site. And what I'm looking for on these x-rays is just seeing the bone density fill on the 2D image. Now, in this case was treated relatively recently. So we're not going to be able to see the follow-up CT scan. But what I do want to show you is that we also test and sample the infection areas. And this is what came up on this patient's report. And this is so, so, so important. So we sample all the goop that comes out of these areas and we send it to a laboratory for analysis. In this patient's case, this is the report that came back. And we did two tests. We did a test for pathogenic bacteria, viruses, and parasites. And we also did a test for Lyme disease because this was a significant part of the patient's history. When we looked at the bacteria, if you look at the test, the bars with the biggest numbers, the biggest red bars at the bottom of the graph, I've outlined them here on the right-hand side. And you can see that there's actinomyces present in the area, which is commonly found in dental infections. And one of its manifestations systemically is diseases in the lungs and also the GI tract, which is significant. The patient also had a parasite in the area, the Entamoeba species. And the parasite has many, many symptoms, including vague GI distress, sometimes can be completely asymptomatic, and sometimes can be as severe as dysentery, blood and mucus in the stool. And this is so important because this is what is living in that cavitation site, and our bodies and our immune system cannot get rid of it. They can just fight it. So think of all that inflammatory signal that is going on in that body. That silent alarm is going off and it's causing disruption throughout the entire organism, throughout our entire body. In this patient's case, we also found Borrelia burgdorferi in the site, which is a Lyme pathogen. All right. So probably sometime around the timeline when either the wisdom tooth were removed or in the infection site of the root canal treated tooth were removed, Lyme pathogens also harbored in that area. And those pathogens take advantage of compromised immune sites, and they can create all the common manifestations we see with Lyme disease without being able to get rid of it because it has this protective area within the jawbone to deal with. So it's, as a biologic surgeon, one of my goals is to try to clear all these sites out so that the patient's body or through medical treatment and intervention, they have the best chance to clear these issues and get their health back. This is how the patient's healing looked. Because of the more minimal access we did in both cases, I used a resorbable membrane in this patient's case. And so at 1 week, we can see that gum tissue starting to heal. There's a nice fibrant clot over that area. And in 6 weeks, the soft tissue's healed over. It's still early. We're continuing to watch this patient, monitor this patient. At 6 months, we will scan him. There are other things we're working on with him, but it's been quite amazing actually, because we've done some supportive therapy with him, which has given us a chance to really check in and see how he's been doing. And I'm really happy to report that he said that he's had significant improvements, especially in the GI aspect, less bloating, more energy. The ringing in the ears has subsided. And importantly, what I hear from him that I hear from so many patients is that, had I known this, I wish I would have done it sooner. And I'm very, very happy that he's found me and we had the chance to take care of it. There are so many patients out there that have these issues. I wanted to highlight these two cases, one to show how extensive cavitations can be and that sometimes they can be associated with pain, and also a case where they've been present for a while and not associated with it, but all the significant health issues and pathogens that are found in those sites. And I think that that's really telling because I'm not so sure patients know this. And unfortunately, I'm not even so sure that many physicians know this. So this is an important aspect to screen. The systemic symptoms are one of the key things to look out for to recommend a screening for cavitations as well. So to wrap it up, a couple key takeaways. Cavitations result from incomplete or compromised healing following an infection or injury to the jawbone. So something has to happen. And that issue sets along a cascade where we have an incomplete healing and a necrotic bone formation in the area. Often cavitations are silent drivers for systemic disease and inflammation, and this is why they play an important role in the health ecosystem and why dentistry is so important in the total holistic health and management of a patient. Diagnosis requires a CBCT scan, and I strongly recommend any treatment should also incorporate surgical visualization. I know that this is not cheap, this is not easy. Between a CBCT scan and even visualization, the cost can be anywhere between $2,000 to $2,500 even before treating it. But I wouldn't recommend building a home without a blueprint. I wouldn't recommend taking a cross-country trip without GPS. And there's really no benefit to go into surgery and risk having infection left behind or causing damage or injury to any adjacent structure that's going to be more costly to repair or deal with down the road because we have this today. We have the technology today to properly diagnose and plan cavitation treatments. Of course, the best remedy of all is prevention. Teeth that need to be removed should be removed following a biologic extraction protocol. If it is done that way, there will be a significant dip in the number of cavitations that need to be treated. But if a cavitation does need to be treated, the body should be prepared. The mouth should be prepared for the surgery. Patients should not run in and just get this treatment done without having a proper assessment and proper supportive plan in place, both pre and post surgery. And I can't stress that enough because patients can herx from these treatments. Patients can have significant immune health decline, and patients can also not be able to form proper bone or tissue in the area if there's not the right protocols in place. So treatment is critical. There is a biologic surgical protocol that should be followed. And this scientific protocol, it's been researched, it's been backed, and it has shown the importance of utilizing minimally invasive therapeutics to access the site, the importance of using bone grafts in addition to the PRF to help the cavitations heal so that there's no residual site, and the importance of using barrier membranes to prevent soft tissue formation and that contraction process that happens when the bone heals. Done all together, this is the proper way to treat cavitations. And my concluding thought is that cavitation surgery is really the most complex surgical treatment there is. often we're going into areas of the jaw that have critical adjacent anatomy. There are nerves in the area, there's arteries, key blood vessels, the sinus might be in the area. And this is not healthy bone we're going into. We're going into an area that's necrotic, that has damaged bone, that has poor blood supply, that has infection. And therefore, the body needs to be properly prepared. And you need to work with a surgeon who has experience in performing this and has advanced training and certification in this process. Fortunately, these things are available. There's a process for this, but unfortunately, there are not a lot of people that do this. All right. And this is one of the key things. This this is not something that should be done routinely by a dentist or someone who's had some surgical training but no biologic exposure. And I highly, highly recommend working with someone who has actual certification from the Academy of Oral Medicine and Regenerative Medicine treatments. So, with that, I want to thank you all for your attention. This is the second time I've had a chance to present to the group here. And so I do want to also leave it off with a special gift for the community here, because I know that this is not something that a lot of people know about. There may not be a lot of access to this, but for anyone who's attended this webinar, who's listened to it, I want to give you the opportunity throughout this month to choose one of the following gifts to use it, whether it's a $100 discount towards any virtual consultations to review the information, or even a $500 credit towards your cavitation treatments. The key is to do this properly, to do this right. I want to promote a message of health and wellness and proper treatment so patients can truly get better, so that there's belief and understanding for the treatments of cavitations. And I want this to be something that is exclusively gifted to you because you've taken the time to learn. You've taken the time to be a part of this, and this is a very special community that I've grown very fond to, to have the chance to present to and be a part of. So thank you all for your time, and I am more than happy to answer any questions I can here.
Thank you so much. That was a beautiful presentation. I know there were a few areas that I was a little squirmy, but you know what? Photos really tell, so much more than you can even describe. And being able to see the pre-op visual of a patient, that first case was really intense. And then seeing how successful it really turned out was just really a nice add to the presentation. So thank you so much for sharing that and being able to kind of show visuals there for those things.
Yeah, yeah. I know it may not be so easy, especially if anyone is about to have dinner soon, but I think it's important to know what they're doing and to really entrust yourself to someone who has experience handling these things because they are very, very complex areas to deal with. And you got to have a strong stomach for it. So
Yeah. Well, I
hard
think a lot of times you hear so much about cavitations, those of you that kind of dig a little deeper and learn about these things, it's out there, but then it's like, what does it really look like? Or what is it really? I know it's a hole in the jaw or a hole in the bone, but seeing that I think is really important because it gives a visual and actually shows you what that is, that you're explaining. So I have a bunch of questions that came in during the webinar. So I'll go ahead and get started if that's okay with you.
of course.
First, Marco Cortina just wanted to let you know when you mentioned no one wants to see you, he said he likes seeing you, Doc. So just wanted to let you
I
know.
appreciate it.
That's
Thank
how we
you.
started. It was great. Um, can COVID alone cause cavitations, or does there first need to be some sort of injury?
Yeah, correct. The latter, right? There has to be some type of injury to the bone. COVID can complicate the body's immune system and the ability to heal. So if a patient's had COVID and then they have a dental extraction and their body is totally wiped out, very high risk for a cavitation to form.
Does dry mouth make cavitations worse?
Dry mouth won't directly make cavitations worse, but one of the key issues with dry mouth is an increased risk for gum disease and also for dental decay. These issues, if left to their own devices, can lead to tooth loss. Tooth loss means that there needs to be an extraction procedure, and that can be risks for cavitations.
I have a question here. I know you touched on this a little bit and showed the example, but how soon after a tooth extraction should someone schedule the second CBCT scan to ensure that all the infected material has been removed and confirm that there's no cavitation? I'm a patient, 77 years old, with my first extraction, number 31.
Yeah, so one of the things that we'll do if the extraction is done with a biologic protocol, meaning that the area is properly cleaned out, a bone graft is put in the area, all the membrane, normal healing follow-up protocols look good, then you can look at that site at 3 months on a CBCT scan if you are planning to replace the tooth with a dental implant. That's kind of the first glimpse. I wouldn't look any sooner than that because the bone density just may not be mature enough. If it is an area that we are not planning to put a dental implant into, I would wait 6 months because you want to see mature bone in that area. And that's something that you will see around that time point in a better way, especially if it's like around a wisdom tooth site or, a second molar site like 231.
How should I prepare my body before cavitation surgery? I know you kind of also touched on that during the presentation, but that was a question that came through.
Yeah, that's a great question. So it's a very extensive question because if there are any kind of inflammatory systemic health issues, they should be addressed first and foremost, if possible. Sometimes cavitations are one of the causes of those things, but you want to optimize the body as much as possible. Certain things we want to do. We want to make sure that inflammatory indexes are as low as possible. Vitamin D levels are elevated. There's been time to properly supplement and make sure that the body has the building blocks that it needs to heal. Oral diseases such as gum disease, adjacent decay, or infections also need to be addressed prior to the treatment of that so we don't recontaminate those areas. So the timeline for this thing can vary and what needs to be done can vary, but it's very important to have a full assessment, a proper assessment, not just orally or dentally for what's going on, but also a deep dive into medical history, medication, supplementations, and that actually I think is one of the great ways to work with the oral biologics team because that's exactly what they do and that's how they help me with patients to make sure that everything is optimized for the surgical part.
Does using red light laser daily to your mouth, so I guess like red light therapy daily
Mhm.
to your mouth, help prevent cavitations or decrease? I'm sorry, help prevent cavitations and increasing blood flow.
Yes, it will help increase blood flow. That's the key. As long as that site, the surgical site, has been properly cleaned out and the body has the reserves and the capacity to heal, red light therapy is an excellent accelerant. It's like putting, top quality fuel into the car, right? It's helping that body recover faster. But the building blocks and the foundation needs to be there. If the extraction or surgical site is not handled properly, unfortunately, red light therapy will not be good enough alone to help prevent a cavitation site. It's only part of the recovery process.
The next question is, what is the specific kind of laser that you use? Do you know if the laser is the same as what Dr. Teresa Scott uses in her process of extraction? I believe you guys all use the same laser.
Yeah,
I
yeah.
answered Photona Lightwalker. I thought that was the
That's correct.
answer,
Yeah.
but correct me if I'm wrong, please.
Yeah, that is correct. The Photona Lightwalker is really the best laser out there for this. It's not the only erbium YAG laser, but that is the type of laser that should be used to access the cavitation. Different lasers are used for different things. So they're a tool. Like a screwdriver is good for screws and a hammer is good for nails. So those differences are important when we want to achieve different things. When we are working on the bone, an erbium YAG laser, an ER YAG laser is the key. The best one available, the most researched one out there for this stuff is the Photona Lightwalker laser.
The next question I have here is there a cavitation equivalent beyond the dental field? I thought that was a great question.
Yeah, that's a very good question. Actually, the way that it was understood and kind of first came on the radar is in the orthopedics field. So orthopedic surgery would sometimes see cavitations form in long bones, right? And so that's like the femur, or sometimes they would see it form around infection sites of implants, like hip implants. And so some of these things started to kind of shed light on the important association between bone, proper mechanisms of bone healing, and seeing that bone is not just really kind of some two by four that we, can work on willy-nilly or put screws into without problem, but there's actually an osteoimmune network, meaning that there's a communication between your immune system and your bone. And this knowledge base has really transcended quite a lot of research and a lot of information. And or the orthopedic world has been really aware of these things for a significant period of time. The unique aspect with the mouth, why cavitations in the mouth are so much more challenging than other areas of the body and why they tend to form more, is because the mouth naturally is an exposed oral microbiome. So that means that when we do surgery on a leg or an arm, it's done in a sterile field and it's closed over by the tissues and there's no bacteria that get into that site. Surgery in the mouth does not operate that way. There's natural bacteria in that area, and that's why the oral microbiome needs to be optimized for health and healing beforehand, and health needs to be maintained after with supportive periodontal protocols because that bacteria can contaminate that site.
Also, during your first case, Dr. Teresa dropped a question in kind of talking about the coronectomies that a lot of times oral surgeons are performing and kind of mentioning that in biologic dentistry, it's something that, it's leaving a dead piece of tooth in the jaw. So she just wanted to see if you could touch a little bit on that part of, what's happening a little bit in wisdom tooth extractions and coronectomies and kind of how they can play a role, like your first case with the tissue
Yeah,
and
yeah,
I'm sorry,
sure.
with the tooth structure still in place there.
Correct. Yeah, yeah. So decoronation is a technique that's sometimes used by oral surgeons to remove the crown or the top part of the tooth and leave some part of the root structure still within the jawbone. The reason why it's done sometimes is if the roots themselves are near some critical anatomy, for example, like the nerve of the jaw, and removing the tooth in full can create a risk of permanent nerve damage. This is rare. This is not the normal situation, but it can happen. And so there's sometimes an indication for it. In my practice, occasionally I will use that technique to remove the root, but I tell the patient we will come back to remove the residual pieces at a later date, usually about 6 months later, because the root of the tooth then can erupt and come out away from the nerve to safely remove it. I don't prefer to leave that root structure intact, especially if it was in a contaminated or an infected tooth. If the tooth was never exposed to the oral environment, that's the only indication where sometimes you can leave that root in place. All right. And the decoronation procedure can be successful. That's a pretty rare situation. Usually there's a reason why the wisdom tooth is being removed, such as gum infection or dental infection. And so, as Dr. Teresa was saying, leaving an infected root or a part of infected root in that area is not a good long-term solution.
Dr. Hamden just mentioned it's such a great case you had, so I just wanted to let you know since I know you don't get to read these. Next
Thank you.
question is, in what percentage of cases do you prescribe antibiotics, antifungals, antiparasitics, or work with a patient whose MD prescribes them due to the pathogens detected through pathology, suspected through symptoms, and or indicated through energetic meridian testing and medication testing? In your experience, is this only needed in the subset of patients who have consistently low immune markers due to genetics, or in patients with complex infections such as Lyme and parasitic co-infections, fungal infections, bacteria in the cavitation site?
Yeah, yeah. So current protocols are to utilize antibiotic therapy as coverage after cavitation treatment. I would say two kind of very important reasons for this. One reason is that even though we've cleaned out the infection, the bacteria, parasites, anything that is in the actual cavitation site, there is still a systemic presence of these bacteria within the bloodstream, and we want to utilize antibiotics to clear that out. The whole purpose of our approach is to try to help the body's immune system deal with the issue. Now, if you don't take the antibiotic, it doesn't mean that it won't heal. It's just more stress on the immune system to make sure that it is able to clean everything up or mop up the mess, so to speak. All right, that doesn't always happen. And so one of the risks is that you may get residual infection or residual cavitation formation. And so that area would now need to be treated again. And sometimes the pathogens that harbor in that site can be more resistant or more toxic to the body. So my feeling is that doing a protocol that is optimized for a single treatment that is comprehensive. We visualize, we know everything they've got to treat, clean it all out, and support the body pre and post surgery. Then antibiotics are a safe and effective way to do that in tandem with the medical physicians. And also probiotics to help ensure that the gut is healthy along the way, and proper nutritional supplements to make sure that the body has the building blocks to recover. So it's not alone, it's not a therapy alone, it just needs to be done as part of a whole here.
Um, the next question is, do you have experience with patients with Ehlers-Danlos syndrome? If so, did any of them ever have issues after or during cavitation surgery? And what or how were you able to deal with that
Yeah,
with them?
so that's one of the most challenging scenarios because it's a connective tissue disease, a connective tissue disorder disease. And the bone and gum are connective tissues. So the body's inability to form partially or fully certain collagen formations make it challenging to manage these cases. The reality is that sometimes there's no choice. We have to treat that because it's a source of significant infection and disease. And in those cases, we really lean in very, very heavily into the pre-surgical protocols, working closely with the medical physicians, medical doctors, nutritionists, and really ensure that we have the patient in the most opportune state to treat it. I actually have a patient right now in our practice with this condition. And we are still working. We've been working now for about 8 months to try to optimize the patient to a state that we feel that they're safe for surgery. And that is one of the key things that I discuss with all my patients is that it is not about rushing to treat this. It's about making sure the body is ready to handle it so that the one treatment works in the best possible way. And we've had success. I know that was one of the questions too. Do you have success with it? Yes, when you do this, it is successful. What we should expect, and if this is a condition you deal with, you should expect to heal more slowly. And there is risk, there is true risk that there can still be residual cavitation that would need to be retreated. So I would tell a patient that has this condition that there is a chance that we might need to go in twice to fully clear out this area over time.
I answered this one a little bit and kind of reverted back to the original webinar that you did, but do you recommend bone grafts only for cavitations, also for tooth and root canal extractions? I mentioned for them to kind of rewatch that original webinar because you go really far into depth with all of that information and talking about different bone graft materials and what you use. So definitely, Laura, if you could rewatch that, I think you'll hear a really comprehensive answer to the questions regarding especially the bone graft material. Um, the next question is with Mary Beth. Is the 3D CBCT scan and the 3D cone beam the same thing? Yes. And then if they are you able to give a virtual second opinion without the patient coming to your office? So Mary Beth, there's that virtual consult, image there on the screen. You can certainly contact the office and that way we can help get you scheduled to have the virtual. Dr. Teresa just mentioned what a beautiful presentation and great job.
Thank
Next
you,
question
Teresa.
from Aylin is very effective and precisely you summed up biologic dentistry. Alex, not only the cavitations, excellent presentation. How about the mycotoxins? Is there a test that you use specifically for that?
Yeah, so that's kind of so one of the key things that we're really looking to try to develop is comprehensive panels for really testing all the different diseases that can be associated or all the different pathogens that can be associated with these sites. So, in tandem with some functional medicine doctors, I've had some kits sent to me for testing specific mycotoxins, specific fungal diseases. We don't have access to that directly as a dentist, but if you give me that, I can test it in those sites and send it off to the laboratory for you. But it's kind of a little bit outside of the usual panels that we have that we can order as a dentist. But I will tell you that it is very, very likely that those things are there because it's a tag-along co-infection to so many of these conditions. So I would say that that is a excellent thing for us to look at as we develop this further.
Also, another comment by Lisette is well done. Loved hearing your passion. As a foundational dental hygienist, this is just another amazing addition to our arsenal of referrals. Thank you so much for your presentation.
My pleasure.
Um,
Thank you.
Next question. What antibiotic do you normally put patients on? Is it clindamycin and how many days?
It's really going to kind of depend on certain sensitivity testing. If we have the opportunity to do that salivary pathogen test ahead of time, there's actually sensitization data, meaning we know what the pathogens are most sensitive to, and we will prescribe that. Clindamycin is commonly used. Augmentin or amoxicillin is commonly used. Azithromycin or Z-Paks are commonly used. So those are some common ones, but sometimes we do need to kind of dig beyond that a little bit too.
How to prepare the body for extraction or other invasive procedures. I know you touched on that, but Mel, if you want to rewatch this again or kind of touch base with our coaching department, we're definitely able to help guide you. There also is a webinar on pre and post-op recommendations that Melissa did, so you can kind of circle back and watch that as well. If you know you have bad bacteria from a salivary test, how do you prevent a cavitation after a tooth extraction?
Yeah, so if the salivary test is showing that there is a dysbiosis, meaning there's a uh, negative oral microbiome or something that's going to be conducive to disease, it's important to treat that area beforehand. So there are certain laser protocols. One example is LANAP therapy. It's a very effective and targeted way to treat pathogenic bacteria but still leave healthy bacteria in that site. So that should be done first and foremost. That goes back to that concept of preparing the terrain. Now, if it's an acute infection and there is no choice but to go and operate, what we do in our practice is we co-treat, meaning that we will treat the periodontal issues or the oral bacteria issues first, and then we will treat the extraction or the cavitation process second, but in the same surgery, meaning that we will do them back to back, but specifically in that order. So at least when we go into the cavitation, that site is locally as clean as possible.
Another question came in, is Ogma bone calcium biphosphate more biological approach than cadaver? What bone do you normally prefer for your highest success rates?
Yeah, so the type of bone graft is one of the key things that is being researched and looked at. Um, the synthetic bone grafts have not shown good outcomes in forming vital bone. All right, and what I mean by that is that what is happening is there's a lot of residual graft particle that actually creates its own source of inflammation. Almost think of it like a residual splinter over time. It helps with the initial healing, but then the body can't get rid of it. And when that issue happens, you now start to get inflammation, fibrous encapsulation, and essentially residual cavitation formation in those sites. So I really tend to stay away from synthetic bone. There the research is pretty clear that cadaver bone grafts form the most vital bone. However, in biologic communities and biologic circles, we're always looking for alternatives to this. And one good alternative that we've found is utilizing a bone graft material called algos. Algos is derived from algae, so it's a plant-based bone graft. And that bone is hydroxyapatite mineral. And actually, Professor Gennady has done a lot of research looking at different bone grafts, and there's certain compositions of that material that should be used in different areas of the jaw, whether it's upper jaw or lower jawbone, to have the most success. So when we actually do these protocols, we get quite specific in what bone grafts we are using. Again, the whole goal here is to try to allow the body to heal properly and minimize the reformation of future cavitations.
Do hormones affect severity of cavitations?
Hormones will absolutely affect the body's ability to heal and therefore the predisposition to cavitations. I don't have any research that definitively shares if hormones will create larger or smaller cavitations or more pathogenic ones, but I can tell you from just treating hundreds and hundreds of these sites over the years, I have seen that there is no direct correlation between even the size of a cavitation and the type of pathogens that are there. So realistically speaking, I think that this is still in the works to be looked at. But anything we can do to regulate hormonal function is critical for bone development and bone healing. So it's proper supplementation and work with physicians to optimize the hormones beforehand really is critical.
Another red light question just about the red light electric toothbrushes are beneficial. Are they worth the money or, is that more
Um,
marketing?
yeah, I think you know what? I'll say this. If you're using it and it's helping with oral hygiene, I think that that's really the kind of the key benefit of it all. The amount of time you're using the toothbrush, which is prescribed to be about 2 minutes twice a day, is probably not enough red light exposure to really kind of make a meaningful difference, to be totally honest with you.
Yeah. Someone dropped a question in. Will every extraction get a cavitation without bone graft? I was prepared to pay for cadaver bone graft, but the biologic dentist I saw told me it was a waste of money if I wasn't going to get an implant done.
Yeah, so this is one of the key things. I love this question because this is so important to dispel. We need to properly graft extraction sites to prevent cavitation formation. That's really, really critical. So whether you're getting an implant or not, the site should be grafted. And we have patients all the time that we'll kind of talk to, and they're concerned about using let's say a particular type of bone. There's a lot of myths out there about cadaver bone. It has been researched for over 75 years. There's no risk of contamination. It is specifically selected and treated, so it's really going to help create normal bone in that site. The main advantage it offers over every other product is that you're going to have the most natural human bone. Your own human bone will form there, and that bone graft will be resorbed. All right, so it is critical for cavitation prevention. Some products better than others, and we'll get into that a little bit more if we want to kind of talk more about that.
That is actually another question that came through if you treat patients without bone graft ever. So the answer is no, right?
Yeah. I mean, look, the answer is that we like treating informed patients, right? And in fact, even to the point of why we're offering, complimentary benefit for patients who've attended this is that most of the time during our consultation processes, we are spending time educating patients on the science. There's not enough doctors out there that know the science because the science is being developed at the forefront right now. And so the information that people are sharing sometimes can be old news, even in the biologic dental community. And I have this conversation with very, very reputable doctors all the time who still say, nope, when I treat cavitations or extract teeth, I just put PRF in there. And the evidence is really clear. You're gonna form cavitations. So if a patient chooses to still go that route, I can't force them to do a bone graft, but I do want to educate you to know what the risks are if you choose not to.
This was a great question. Laura asked, do you screen patients to confirm if they're no longer living or working in a moldy environment when undergoing extractions? I've heard of people getting infected or reinfected if they're in moldy environments before the wound is fully healed. Seems something, important that they should be screening for.
Correct. Yeah. Environmental factors are a big deal, and it is one of the things that we talk about. I feel very fortunate to work with a great group of functional medicine doctors, especially who, on a referral basis, give me a lot of insight on the things that they're working through with the patients. I will say environmental toxins are a really big one. For some of our patients that don't have acute symptoms and are in a manageable state, we will wait for the patients to relocate or remediate those issues, and that happens a lot. Sometimes patients have acute issues like an infected tooth that's in pain, and we don't have any other choice other than to treat it, in which case we really lean in heavily on the supportive protocols afterwards for healing. And we're a bit more vigilant with those patients to make sure that we get them on schedule to monitor and see what that site looks like at 6 months. But sometimes we tell them, like, look, there is a chance there's going to be a cavitation here. We prepare them for it. And if there is, then we will go and we'll treat that.
All right. I think we just have one other question that came through here. How to strengthen the oral microbiome?
Yeah, so that's a great question. So the oral microbiome is composed of a few different components. One is the indigenous bacteria that we have in our mouth, and so there's close to 700 species that make up the normal oral microbiome of our mouth. In health, things that you could do on a daily basis, like proper hygiene techniques, the incorporation of a healthy diet, are critical ways to make sure that that environment is in balance. Professionally, I would recommend at least every 3 to 6 months, depending on your inflammatory risks and salivary markers, to have
Hmm.
a professional hygiene cleaning, which is really, really critical to make sure that some of the deeper spots or the tough to reach spots are treated. And I encourage patients to do salivary diagnostic testing at least once a year because that will give you insight about the oral microbiome prior to symptoms developing. You don't want to wait for the gums to bleed. You don't want to wait for the hygienist to tell you, "Hey, listen, you're developing pockets or you have gum disease." That is like looking at the 2D X-ray and waiting for that infection to show up there. All right, we have ways to know about that beforehand, so that's really, really critical. And again, I'm going to lean in one more time to say how important it is to work with the oral biologics team too, because there is a systemic component to this too. If your body is in a more inflammatory state, or your nutrition or your diet is pro-inflammatory, that's going to help create an environment where pathogenic bacteria thrive. On the converse, if you create a healthy environment, a healthy diet, it will compete with those pathogens. And so that's really kind of the key. So it's multifactorial between things you do, things we can do on the dental side, and things that can be done on the supportive and nutritional side as well.
Thank you so much. I am going to end your questionnaires there. I appreciate you taking the time, and I hope everyone had an informative experience tonight, learning more about cavitations and how they could be affecting your body. Again, Dr. Volchonok can be reached at the TetraHealth office. There's an office in Manhattan and an office in Greenwich, Connecticut. The information, I intentionally left it on the screen there so you could take down the contact info if you'd like to directly connect. If you need help ever with any of the webinar providers that we have and you're interested in meeting with them, becoming a patient and you need a little assistance getting there, feel free to always email us at admin@aurabiologics.com. We're always, readily available to help kind of get you connected with the right provider and do whatever we can to help you in your healing journey. So thank you again for joining us tonight. And please, have a wonderful evening. Try to stay warm. I know everybody's in these freezing temperatures. And, we look forward to seeing you next weekend. We're going to make some changes. I mentioned last week, but we'll make some changes to the scheduling coming up starting March. But next weekend, we are doing a talk, I believe it's with Dr. Julia on airway and children's facial development. So that's going to be a great one for all the parents out there. But any questions that came in that you remember later, you think about after the fact, feel free to email us. I'm happy to forward the information and kind of get you connected with the office. So thank you again for this evening. Thank you, Dr. Volchonok, for being with us, and everyone have a wonderful night.
Yeah, thank you all. It's a pleasure to join with the community. Everyone stay safe, stay warm, and thank you. Yeah, we're here for you for anything you need. Appreciate it.
Have a good night.